I'm Kasey Miranda. I'm a student physical therapist assistant at Jefferson State Community College, and I'm here to talk to you guys about some interventions for burns. So, my handy dandy clicker. Alright, so first off, what is a burn? So it's damaged tissue resulting from excessive exposure to thermal, chemical, electrical, or radioactive agents. So originally these burns can be put into first, second, or third degree burns, but now they're talking about, they changed it to superficial, partial, and full, like the levels of how deep the burn is. So without proper intervention, the thermal energy with the burn can continue to absorb the tissue and get damaged and get worse without doing these interventions we're about to talk about. Alright. So this intervention is kind of more, has to do with wound care, which is part of therapy. So this one's debridement, which is removing blisters and loose skin, and I picked out some pictures for y'all so you can visualize that. Picking out the dead, necrotic tissue, and so this will help heal and let the healing tissue come together. Alright. So this one is talking about dressing it probably after you've cleaned it out and debrided it. So this is closed dressing considered when you're putting gauze over it and covering it from infection. So you're using sterile gauzes and Band-Aids and stuff like that. And then open dressings is like just putting topical antibiotics on it without putting any covering on it, just to let it sit and heal. So one of those examples is the silver sulfadiazine cream. Alright, so here's some more topical agents I've listed for you. So you've got Silvadene, sulfamylon, Trivase, Epiloc, and then there's Xeroform, which is this yellow looking gauze right here, and it's actually impregnated, which kind of means it feels like there's petroleum jelly on it. It just keeps the wound moist. So then you have mercurochrome and then preparation H, and so a lot of these come in little bottles like that, or the Xeroform in little sterile packages. Alright, there's some more interventions for pain control also. So one of these is the TENS unit, which is that Easton tingling electricity feeling that some of y'all might have had with physical therapy in the past. So this is after the burn has completely healed and it's starting to kind of itch, and so that might relieve some of the itching, is that TENS unit. And then there's ice, medication, over-the-counter stuff, relaxation skills like breathing exercises, relaxing, music, distractions, anything to keep your mind off of that burn that might help with pain relief. And then there's group therapy, counseling, and support groups. Just have that support and family members helping you out with it. Okay. So interventions with exercise. Exercise is pretty significant also. So you want to get the patient to do assistive active range of motion or active range of motion, which is either you helping them do the exercise or them doing it by themselves if they can, as soon as possible with starting therapy. And so if the patient can't move by themselves or at all, you're going to be doing it for them, which is called passive range of motion. And then you want to start ambulation as soon as the patient is stable, just to get them up and moving and making the healing process quicker. And then bandages, you want to have them off as early in the rehab phase when working with patients with burns. And then you want to create exercises that are for that patient's burn that kind of are functional for that specific patient. So like if they have a burn on their hand, you're going to want to keep that hand in mind but still kind of work with that range of motion with it. And so I think I have some pictures on this next slide of, so like this guy, he has a pretty bad burn, and he's moving his hand up and down, doing some exercises with that. And then this looks like an older burn. This guy's kind of taking his fingers and screwing, working that burn around his fingers. Alright. So positioning and splinting is also another intervention that's pretty important. So why should we position patients every couple hours to avoid contractures, which is like when you get in a comfortable position and then like your elbow gets kind of stuck, or like in that joint you can't get it out of that position and it just gets stuck. But yeah, so we don't want the patient to allow themselves to get in a comfortable position, just because of that. And then splints, they want them to be on for at least 3 days to make sure the skin grafts, that they have to have skin grafts to hold in place. So here are some examples of them being positioned with their arms laid out. Their legs are probably spread out too if they have burns down there. And it's just kind of looks like a universal positioning for someone that has bad burns. And so you can only imagine how comfortable that can be, just sitting there like that. So then that's references from all my, the end.